Good evening.
Good evening. Good evening.
Can
How are
see
you
us?
guys?
Can you hear us?
Yes, I can hear you very well. And I would like to thank you for joining the gym session sponsored by Medtronic India. And we are looking forward to seeing your cases and your presentations.
Yes.
I understand that Dr. Ashok is stuck in an emergency and Dr. Colombo is a little bit late. So I will moderate and look forward to seeing and hearing your case.
Very nice. So first of all, thanks, Jim, for the kind invitation. And it's an honor and privilege to have a live case being transmitted from Department of Cardiology, PGI, Chandigarh, India to the gym. Let me introduce my team. I do have Dr. Basant, he's assistant professor in the department with me. Dr. Ganesh is there, he's a senior research fellow working with me. Dr. Chaudhary is there, he's a fellow working with me. And we do have Puneet, who's looking after the intravascular ultrasound. So let me ask Ganesh to present the case.
So, good evening everyone. This is a case of, the index case is a case of 56-year-old male with a history of diabetes and chronic stable angina with complaints of progressive dyspnea over last 3 months, class 2 to class 3, and angina on exertion of class 2 in last 2 months. So, clinical presentation and examination is unremarkable, and ECG suggestive of baseline ECG showed resting STT changes. And this is the echocardiogram which is showing good LV function. Next please. Next slide please. And TMT stress test is positive for inducible ischemia. There are significant changes in stage 2 and persisting into recovery, and stress echo suggestive of lateral wall, anterolateral wall hypokinesia. Next slide please. This is a coronary angiography which shows a calcified left main along with calcified LAD and mid LAD lesion of 80% along with calcified LCx of 99% with TIMI1 flow. Next slide please. RCA is mild diseased and LV angiogram showing fairly good LV function. Next slide please. So our plan is PCI to LCx, calcified LCx and calcified left main bifurcation.
So can you show the first cine, please? First cine. So this is the first cine. You can very well see it's a right dominant circulation, and Ostial LCx is near cutoff and it is markedly calcified. Same is true for the left main and also the proximal to mid LAD. Next view. And this is the mid LAD, which is again having a disease, and D1 is around 70 to 80% stenosis. Next. This is a spider view having a very tight stenosis of the Ostial LCx. Next view. So just hold on. So this is what we are with. We do have a left main calcification, Ostial LCx, which is near cutoff, mid LAD and D1 is disease. So any comment about?
Well, I tell you, what I see is a complex, very nice case. I have to say though, the pictures are not very clear, so I'm a little bit guessing. I see that Dr. Colombo has joined. Welcome, Dr. Colombo.
Hi, welcome everybody. Sorry for the delay.
Good evening.
No, that's good. Dr. said Ashok is stuck in an emergency and we are seeing a case. I opened the symposium, great team. The slides were a little bit defocused, so I couldn't really see any details, but basically they explained the case. Now you can see it very good.
Okay, now I can see it.
So this is the angiogram, Dr. Colombo. It's a calcified left main proximal LAD diffuse LCx disease, which is again calcified and near cutoff of the ostial left circumflex.
Okay, can we see the cranial to see the mid LAD, please?
Next, please. So this is the mid LAD.
Okay.
Which is again the tight stenosis. Diagonal is tight, around 70 to 80% stenosis. Next. And this is the spider view.
Yeah, that's a good one.
Okay, there is no question that the circumflex, if you plan to treat, will need a stent, no question.
Yes.
The anatomy of the left main, which is most probably needs a stent, unless you accept to leave the chunk of calcium, I believe is fine for T-stenting. You may get away with T-stenting because the angle is 90 degrees.
Absolutely right. So next you. Next. So this is I initially used BMW choice PT wire, which was not able to cross. Then it's with the help of the micro catheter, we could cross filter XT wire across the LCx. Next you. Here, neither a smaller balloon nor a micro catheter was able to cross. So it's basically a non-crossable lesion. So I was not able to push the micro catheter from this point. Any comment about how to proceed further?
So no, you were able to cross the circumflex. And
I could cross it with the filter XT wire. And this is the micro catheter which is at the Ostial LCx.
yeah.
So
And now you go.
here I got stuck up. Neither a balloon, a thermo balloon of say 1.5 is crossing it, nor a micro catheter is crossing. Okay, next. So this is the position of the micro catheter. And at this position, I did push the rota floppy wire, which could cross it.
Yeah.
So sometime when the balloon and micro catheter uncrossable lesion is there, you have to park the micro catheter at the site of the lesion, and then try to negotiate the rota wire across. So here, this is the rota wire which is there in the distal LCx, micro catheter at the ostium, and not able to cross it. Next. So this is what rota wire in C2 across the LCx. Next. And this is a 1.25 rota bar. Next. Which with initial some difficulty we were able to cross it. Next. So this is what? A diffuse left circumflex disease. Next. Next. So we did dilate it with 2.5 15 millimeter balloon across the proximal and the distal left circumflex. Next. And this is the result. Still there is the Ostial LCx which is having disease. Next. And this is a 3 millimeter balloon with which we have dilated the left circumflex.
Mm-hmm.
Next. Next. Sorry, back.
So what wire did you use for the LAD?
It's a wire. The wire across the LAD is a BMW.
I see.
Wiring of the LAD was not a problem, and this
Yeah.
Ostial LCx lesion we are dilated with 2.5 millimeter flexion cutting balloon as well. Next. Next. This point we did the intravascular ultrasound across both LCx and also the LAD. Can you show the IVAS of the LCx? So can you see the IVAS on the screen?
Yes, we can see. Very calcified.
So it's a very calcified 360 degree arc of calcification. The size of the distal LCx is 2.75 to 3. Approximately it's a 3 and it's a totally calcified lesion. This is the left main. Left main is having some eccentric calcification. Sorry. The size is 4.5. Next run across the LAD. So this is the run across the LAD. It is again markedly calcified. The size is around 3.5 proximally. And this is the left main. There is a eccentric calcification, but the area is how much? 10.5. How much?
10.5.
So area is as Dr. Colombo, you have rightly mentioned about that one can go ahead for the T stenting instead of say putting a stent across the left main. As the intravascular ultrasound did show a good result, a good size of the left main, we can very well discuss whether to put a stent across the left main or not. Next. So this is the cutting balloon after doing the IVAS. It's a 2.5. Next. And this is what the result we had. It's a diffuse calcified lesion. Next. This is the stent 2.75 34 resolute, which had a difficulty in crossing across. Next. So a smaller one, 2.75 28 or 30, could cross it. At this particular point, it was not able to cross distally, so we did deploy over here. Next. We do have certain residual lesion distally as well.
Right.
Next. And this is 3 millimeter stent across the Ostial LCx. So it's a 3 into 20, 322 resolute. You can very well see the ostium of the LCx is having some residual stenosis. Next. Sorry. So this is the one.
What did you use for rotablation in the circumflex?
Sorry?
Which size bird did
It's
you
a 1.25 bar. 1.25.
I mean, retrospectively, what about having used the second burr, like 1.75?
Yes, you are right. Retrospectively, you are absolutely right. With such a calcification, I should have used the upgraded size of the rota bar. But then I did use the cutting balloon across the ostial left circumflex, which could dilate it. But retrospectively, you are right. Maybe a 1.5 or 1.75 bar should have been used. But then there is a concern about, say, left main, and therefore I didn't go so aggressive for the left circumflex. I thought as I could, there is a flow across the LCx, and let's dilate it with a cutting balloon followed by stenting. Next. So this is the 3 millimeter balloon which I inflated at 22 atmosphere across the left circumflex. Next. Back. So this is the result across the left circumflex, which is satisfactory. Let me go ahead and do the IVAS across it. But before that, yes, please.
Would you do an IVAS maybe for the ostial circumflex?
Let me go ahead. Next view. Here, then I had dilated the D1 and also the LAD. Next.
Yeah.
Previous view. Here, if you see, after dilatation of the D1, there is a balloon rupture across the diagonal. It's a markedly calcified lesion. But I could dilate the mid-LAD lesion very well with a 2.5 millimeter balloon. Next. So here we are with you now live. So diagonal, which is markedly calcified, the ostium not able to dilate with a 2.5 balloon, could dilate the LAD. So let me go ahead, do the IVUS across the LAD. If I'm able to cross the IVUS catheter across the diagonal well, and also the LCx.
So, what is your plan with the diagonal?
Diagonal, as it is flowing, let me leave it as such for the time being.
Yeah.
What's your opinion about? So, with such a calcified lesion which is not dilatable with the balloon, let me
Yeah,
leave.
I think you made a point. I think that's a very good point that you're making to maybe leave the diagonal like that, and focus on the LAD.
That's
I
right.
think, Antonio, what do you think?
I totally agree. I think the diagonal will be a long time. I will just keep it open, leave the wire and concentrate on the LAD.
So let me go ahead and do the IVUS across the LAD. Go ahead. Yes. So for the time being, any comment about the Ostial LCx, as I have already dilated with the NC balloon at 22 atmosphere.
I don't think, unless you have some new device like lithotripsy, it's very difficult to make it better. You have access to the OPN balloon, very high pressure balloon.
So I am having certain difficulty in crossing the IVUS catheter. Let me study over here what the size of the LAD. So can you see the IVUS?
Yeah, we
Again,
can see.
a calcified lesion.
Yeah. I think you need another dentist approach.
Yeah, it's circular calcium, Antonio. That would be a good case for shockwave.
Amazing. But you have to do rotablation. What can you do? If you don't have shockwave, do rota.
So this is the left main. The left main area is fine.
Yeah.
My God. I guess in India, is it so common to have so extensive calcification in India?
Yes, the diabetic population is too much, and then we do come across here. This index patient is also diabetic, so we do come across diabetic patient with marked calcification. So what are you doing?
I think you have to do rota.
3 millimeter balloon. What's the size of the LED? 3 millimeter. So let me dilate it with a 3 millimeter NC balloon followed by stenting. Do you feel there should be a rota which should be done at this point? Actually, the problem with mid-LED is...
I don't know about. I will go rota.
Okay. So let me dilate it with
Eberhard.
I think so too. If you don't have lithotripsy, I think you should, because it's circular calcium. You used a cutting and the circumflex, and I think I would use your rota in this case.
Okay.
And if you do, maybe you start with 1.5, or do you plan to start with 1.25?
Okay. Let me go ahead with a 1.25.
Yeah.
Microcatheter.
So, chalo. Microcatheter. Very good wire डालना इसमें. Wire डालो BMW.
BMW.
So meanwhile, by the time I do complete the rota across the LAD, if it's okay, you can switch over to some oral presentation. Is it okay?
That's perfect. So we will get back. Do we come back to you then?
Yes, please. By that time, I will be able to do the rota across.
Okay, we will come back. How long will be the oral presentations?
If you got it.
I don't know, Antonio. I think. Oh, wait a minute. It is 10 minutes.
10 minutes.
It's a 10 minutes.
10 minutes oral presentation. So take your time. We'll be back with
Okay,
you.
okay.
Let's start the oral presentations.
You introduce the next one?
Cranial.
I don't have in front of me the...
So the next plan is learnings from left main interventions from Dr. Navaisundi from Bangalore.
Thank
Oh,
you.
there he is. Great to see you. Welcome.
My pleasure, and it's an honor. Dr. Colombo and Dr. Dubey, it's been one of the best days there. So, if I may be permitted, can I present my case?
Can we have the presentation? Can we see the slides?
Yeah. I will just start my presentation.
Yeah, you can share the screen maybe.
I will. I am so sorry, it's taking a while. Are you able to see the screen, please? No.
No, I think what they have to do is they have to unshare the live case and share the screen with you.
Are
Because
my
we're
slides?
Okay, here we go. Yes, now we see you. Perfect.
He's ready?
He's ready. I just saw his message. He's ready.
Okay.
So, back. 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 So, here we left after having a dilatation of the mid LAD with 2.5. Next, as suggested, that rota should be done over here. I try to put the wire pushing the wire across. Next. And therefore, I did dilate this lesion with 3 millimeter NC balloon. Next. This is the 3 millimeter NC balloon. I did try to push the cutting balloon 2.5 across, but it didn't cross. Next. And then this is a 3 millimeter stent, which again had certain difficulty in pushing across 3 into 20 resolute. Next. And this is what we have deployed the stent across. Next. This was dilated with 3 millimeter NC balloon. And this is the result across the LAD. Markedly calcified tortuous mid part of the LAD. Next. Here the IVAS again because of back. IVAS couldn't cross this particular site. And can you show the IVAS? LAD, IVAS of the LAD. So this is the point just proximal to the stent. Again, it's the same calcified LAD with no significant stenosis. And the left main is okay. Here comes the left main. Next. And this is the IVAS across the left circumflex. Can you run the IVAS across the left circumflex? So this is the IVAS across the left circumflex. The ostium of the LCx is having markedly low area. It's how much? 2.3 millimeter square. Next. So here we have dilated this Ostial LCx with OPN balloon 3 into 10 at 30 atmosphere. Next. Next. The result has improved across the Ostial LCx. Repeat IVAS been done. This is the repeat IVAS across the Ostial LCx. The area gain is around 4 across the LCx. Next. Next. This one. So this is what the final result across. This is the final across the LAD and epicaudal. Diagonal is flowing well. And this is the LCx. Any comment?
Yeah, so I think the diagonal that you left it, I think it's a good choice.
Yes, it's flowing well.
It's stable, it's perfused, and it doesn't complicate the situation there. I think the circumflex looks very nice. Am I wrong? Maybe I'm missing this on this image because it's not perfect. It's a little haziness at the bifurcation. Is this
Yes, there is a certain haziness, but then we have checked in the IVAS, the area is around 10 plus.
Yeah.
So maybe we can have a check angiogram and follow up to look for how the thing is progressing across.
Mm-hmm.
And also for the LAD.
Yeah, very nice. So what kind of bird did you use in the LAD? 1.25?
No, it's a 2.5 followed by 3 millimeter NC balloon across the mid LAD.
I see, yeah.
And I couldn't cross the 2.5 10 cutting balloon. That's flagstone
Okay.
from the Boston.
Okay. Any other comments from your side, Ashok or Antonio?
I think considering the amount of calcifications and the fact that they don't have other devices besides high pressure balloon, I believe this is an acceptable result. Nevertheless, my opinion is that maybe a more aggressive usage of rotational arterectomy would have helped.
Very right.
I must say, of course, the case in the middle, I guess this is, you ended up in a calcified bifurcation with a DK crush. Is that right, Vijayvergiya?
No, sir, it was a Ostial. Can you go for the next view, diagnostic? So this was the lesion.
Right, okay.
Ostial LCx, so we did the rota across the LCx and the left main was okay. And then after doing the LCx, we went ahead for the mid LAD stenting.
Fine,
And nothing was done for the LAD ostium and also the left main.
Got it. And whatever, I guess, whatever haziness we see is still some residual calcium. And you said,
Yes, that's absolutely right.
so when the residual calcium gets next to the stent, you actually have this sort of appearance because you just see much more of it. But if you had a good IVUS, great. I mean, I'm surprised that you didn't go in for a IVL for this heavily calcified ostial circumference.
As the area was okay, it's a 10 plus, therefore I didn't enter in the left main at this moment of time. Maybe at the follow-up, I can again have a check angiogram done and look for how the result are.
Sure. Well, what Dr. Colombo suggested was a larger burr or perhaps an IVL for the ostia. You went for ultra-high pressure balloons. We would
Yes,
prefer to crack the calcium prior to ultra-high pressure balloons, if I had a preference.
Very nice.
Thank you. But a great result.
Yeah.
Thank you.
Okay. I think we should move on, right?
Okay, thank you very much. Thanks everyone.
Thank you very much. Congratulations. Thanks for joining.
Thank you.
Bye bye.
Bye. Bye. Good night.